Hi, and welcome to RadOnc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY4 resident in University of Pittsburgh, and in today's talk, we will be reviewing some common dose constraints. This is really meant for medical students and junior residents that are starting out, and to kind of just review some very generic common dose constraints that you should be aware of. This talk is a nice sequel to the last video that was uploaded that went over how to think about understanding dose fractionation and how that plays into toxicity when we're thinking about our radiation therapy doses. And in that talk, the biggest things that we talked about is that number one, radiation dose depends on many things. So you can't just compare the total dose, because if the dose per fraction is different, then you're not comparing apples to apples. You really need to think about the total dose, the dose per fraction. You also need to think about the alpha-beta ratio of the tissue that you're looking at and how sensitive that tissue is to fractionation. Remember, late responding tissues tend to have higher alpha-beta ratios and they are more sensitive to fraction size compared to early responding tissues, which have a low alpha-beta ratio. Total treatment time is also very important. There are some radiobiological equations that can kind of account for this, but the most basic equations that we often use in clinic, including the BED, which is the biologically equivalent dose, as well as the EQD2, which is the equivalent dose in 2 gray per fraction, these take into account the dose, the dose per fraction, the number of fractions, and they take into account the alpha-beta ratio, but they do not account for the time. These equations for BED and EQD2 are listed here, and you can also just go to eqd2.com and type in the parameters for any radiation regimen that you're using. And if you want to kind of be able to compare apples to apples, some easy ways of doing that are to convert your dose and your dose per fraction. So let's say you know that you're doing something and you're treating lung SBRT 50 gray in 5 fractions. You can take 50 gray total dose and 10 gray as your dose per fraction and calculate the BED for that, and then maybe use that BED, or if you're using the EQD2, you can compare it to other slightly different regimens with a different dose per fraction. So this is a very complicated concept, and if you need further review on this, I would recommend going back to the previous talk where we talked about understanding dose, fractionation, and toxicity. But it's really, really important to understand that radiation dose is more than just the total dose that we're delivering. There's a lot of other complex factors that goes into it. The other thing that we should, really remember from that previous lecture is that early responding tissues and late responding tissues should not be confused with acute and late side effects of radiation. Both early and late responding tissues can have acute side effects as well as late side effects. Acute side effects are the side effects that happen either during the course of radiation or in the immediate couple of weeks that follow radiation. And these acute side effects, just like any acute injury, are characterized by inflammation. And acute side effects are generally a function of the total dose. On the other hand, late toxicities happen months to years out from radiation, and these toxicities are characterized by fibrosis and sclerosis, so scarring that happens long term. And late toxicities are generally a function of the dose per fraction. So if you're trying to compare late toxicities between 2 different regimens, the easiest way to do that is to calculate the BED of those 2 different regimens and compare, whichever one has a higher BED will have a worse late toxicity. So how do we apply all this stuff clinically? How do we actually design dose constraints when we're creating radiation plans? So number one, as we said, it's going to depend on the dose per fraction. To give you an example, for the spinal cord, if we're treating at 2 gray per fraction, we can tolerate somewhere to a maximum of around 45 to 50 gray generally for the spinal cord at 2 gray per fraction. If we're treating the spinal cord with SBRT in a single fraction, then that dose is much lower and it can only tolerate somewhere around 12 to 12.5 gray in a single fraction. So it depends on the dose per fraction. When we are thinking about dose constraints, we also really have to consider the alpha-beta ratio. So, as we said previously, we can take a given radiation regimen, a total dose divided by the number of fractions, and we can either use the biologically equivalent dose, or we can do an equivalent dose at 2 gray per fraction and kind of get an idea of what that is doing in conventional fractionation. So when we do that, it's really important to consider the alpha-beta ratio of the tissue that we're treating. For most normal tissues, the alpha-beta ratio is going to be around 3. Now, this is a very general approximation. It is hugely oversimplifying complex radiobiology. In reality, there are radiobiological experiments for different organs, and all of these alpha-beta ratios vary slightly. And a given tissue can actually have a different alpha-beta ratio depending on if we're looking at an acute toxicity or if we're looking at a late toxicity. So alpha-beta ratio of 3 is hugely oversimplifying it, but it is a useful number to keep in mind when you are quickly evaluating a radiation fractionation regimen in clinic. For the spinal cord, we actually will sometimes use a more conservative alpha-beta ratio of around 2, just because we know that the spinal cord is exquisitely sensitive to fractionation. And the lower that alpha-beta ratio, the more sensitive these tissues are to fractionation. So dose per fraction matters, alpha-beta ratio matters, and finally, it's really important to consider the organ that we're treating and that we're actually prescribing a particular dose constraint. What is the function of that organ? How does that organ actually work? And that's where we get into this idea of series organs versus parallel organs. What do we mean by a series versus a parallel organ? It's actually the same concept as series versus parallel circuits in electricity. In a series circuit, any given loop is designed so that all of the bulbs are directly connected to one another. And so if one of the bulbs goes out, the entire thing breaks. A parallel circuit, on the other hand, is a type of circuit where things are connected in parallel to one another. So think of it as a small circle and then a bigger circle and then a bigger circle, but they all convene on that same battery source. So if one of the bulbs were to go out in a parallel circuit, the other bulbs would still have electricity. So going back to human anatomy, series organs tend to be long tubular structures. Think of things like the spinal cord, the brainstem, the optic nerves, the bowel, a long tubular structure. And with these structures, it's just like a series circuit. So if you poke a hole in it, in any one area of this organ, the whole thing is going to break, right? If there's a spinal cord dissection in the thoracic level, then everything inferior to that thoracic level is going to be affected. And same thing with the bowel. If you poke a hole in the bowel or even in the stomach up top, the whole thing is going to break. So typically, series organs, their toxicity is dependent on a maximum dose because, like we said, if you poke a hole in it, the whole thing breaks. So these organs are very sensitive to the level of a maximum point dose. On the other hand, parallel organs are organs that are kind of arranged in concentric functional units, just like a parallel circuit. So think of things like the lung, the liver, the kidney, the parotid gland. These are all organs that have functional subunits. For example, for the lung, we have the alveoli. For the kidney, we have the nephrons. And there are multiple of these functional subunits that are all arranged together. So we really only see end organ damage when enough volume of those functional subunits is damaged. So if you damage enough of it, enough of a volume, then it's going to break. And so for these parallel organs, we worry more about causing toxicity by exceeding a threshold dose to a particular volume. So for parallel organs, our toxicity tends to be more dependent on a volumetric dose or a mean dose. So series organs, if you poke a hole in it, the whole thing breaks. We really worry about a max dose with these serial organs. And then with parallel organs, we worry more about a volumetric dose or a mean dose because it's really about exceeding a threshold to a particular volume of that parallel organ. Now keep in mind that for certain organs such as the bowel or the bladder, we will often see both a maximum dose constraint as well as a volumetric dose constraint applied. But it's really important to kind of have this sense of which organs tend to be series organs versus which organs tend to be parallel organs. And then in reality, when we are designing our radiation plan and we're actually prescribing dose constraints to certain things, we can sometimes use a combination of both maximum dose as well as a volumetric or a mean dose. So hopefully now we understand series organs versus parallel organs. The last little concept I want to review before we actually go into dose constraints, some practical dose constraints that you should remember for clinic. I just want to briefly talk about the terminology of dose constraints. This can be very confusing to grasp if it's your first exposure, and so I'm going to try to explain it in a way that makes sense. When we're talking about dose constraints, as we just said, we have all types of constraints, right? We can constrain a maximum dose. We can say a certain organ should receive no more than a maximum dose of X gray. We can constrain the mean dose. So the mean dose to the volume should be no more than X gray. Or we can constrain it volumetrically. So we can specify a particular volume should not receive any more than a certain dose. So when we're describing all these constraints, we use a certain terminology or a nomenclature. So I just want to review some examples of that. So one thing that you might often see is something that we say is a V 50% or a V 20% or a V 90%. Whenever you see V 50%, the number on the other side of that less than or greater than sign is going to be a volume. So V 50% means the volume receiving 50% of the dose should be whatever's on the other side of that sign. So in this case, the volume receiving 50% of the dose should be less than 50%. So in other words, 50% of the volume should not get more than 50% of the dose. Okay? So V 50%, whatever is on the other side of that less than or equal to sign is going to be a volume that we're talking about. So when we say V 50%, we mean the volume receiving 50% of the dose or more should be less than 50%. When we say V 15, what we really mean, and it gets tricky because you have to know if you're talking about a percent or a dose, and that should typically be specified. You can express the volume receiving 50% of a dose, but you can also express it as an absolute dose. So you can say V 15 gray, so that means the volume receiving at least 15 gray, the volume receiving 15 gray or more, should be less than 50%. So anytime you see a V something, whatever number is on the other side of that sign is going to be referencing a volume. On the other hand, if you see a D on the left side, whatever number on the other side of that sign is going to be representing a dose. And so then that subscript or whatever is attached to that D is typically referring to a volume. So one thing you might see is a D max or a dose to 0.03 cc's. D max, and sometimes we look at 0.03 cc's as the D max just because that's the size of a voxel. But D max really refers to the maximum point dose. So if we say something like D max should be less than or equal to 110%, what we mean is that the maximum dose should be no more than 110% of our prescription dose. So if the first letter is a D, then whatever number is on the other side of that less than, equal to, or greater sign is going to be a dose. And then finally, you can also express it as a percentage. So you can say D 90% is greater than or equal to 100%. So that is saying that the dose to 90% of the volume should be at least 100%. And if we're trying to make sure that a certain volume gets at least 100% of the dose, then we're probably thinking about one of our target volumes, such as our planning target volume. This is saying that at least 100% of the volume should receive 90% of the dose. So this terminology can be quite confusing. The easiest way to think about it, and whenever you're looking at these numbers for the first time, you will have to kind of hear a volume and then think about what that means, or hear a dose constraint and think about what that actually means. But if you see a V as the first thing, then whatever number's on the other side of the sign is a volume. If you see a D as the first letter, then whatever number's on the other side of that sign is a dose. So that's the easiest way to kind of think about this. The other thing, as I alluded to, we can refer to a V50, and it might mean the volume receiving 50% of the dose. It might mean a volume receiving 50 gray. It's really important to, when you're looking at whatever protocol, if it's giving you dose constraints, or if even if you're just talking in the clinic, and if you're not sure what somebody means when they say V50, ask them to kind of specify. As you get comfortable in clinic, you'll kind of get a sense and you'll know what makes sense when you're used to dealing with these numbers. But if you're starting out and you don't know what they mean when they just say V50, do they mean a percent or do they mean a gray? Just ask them. Or if you're looking at a protocol, look it up and make sure that it's very clear to you. Because, the radiation dose is a huge safety matter. And if you're not sure about something this critical, then this is definitely a place where you want to ask about it. Okay, so with all that background in mind, let us now get into a discussion of some practical dose constraints that are good to remember for the clinic. There's an important series of papers called the Quantech studies that give us a sense of dose constraints when we're using conventional fractionation. So we're using 2 gray per fraction. So let's take a look at the spinal cord as an example. There's different papers for different constraints, but I think spinal cord is a good one to focus on. So with spinal cord, the biggest toxicity that we're worried about causing is a long-term risk of myelopathy, right? Myelopathy is a side effect that happens from damage to white matter in the spinal cord due to radiation. And it can occur subacutely. This is usually from transient demyelination, happens 4 to 6 months after radiation, but it's usually self-limited. What we're really worried about is causing a chronic and progressive type of myelopathy, which is irreversible. It happens months to years after radiation, and it can cause quadriplegia or paraplegia, depending on where in the cord the injury is. And it's a really terrible side effect of radiation that we try to avoid at all costs. So the Quantech experiment for the spinal cord, what they did is they looked at the equivalent dose in 2 gray per fraction for many, many patients, and they looked at whether or not those patients developed this permanent myelopathy from radiation. And based on this data of the equivalent dose in 2 gray per fractions and whether or not these patients developed myelopathy, they created these normal tissue complication probability curves. These are called NTCP curves, and they tell us the probability of having a particular side effect at a particular dose. Now, these curves are not perfect. They are kind of a mathematical extrapolation of real life data, and they're not perfect. That's the answer, but they do give us a good sense of the probability of causing a particular side effect. If you look at the curve pictured here on this slide, you'll see that it has kind of a sigmoidal shape. So if we're looking at EQD2 of around 40 to 50 gray, there's really not much risk of causing myelopathy, right? That risk is very, very low. If we look at 50 to 60 gray, we start to see a small uptick in the probability of causing myelopathy. If you go from 60 to 70 gray, though, that dose suddenly jumps up dramatically, and we get a huge increase in probability. And then from 70 to 80, it continues to increase. And if that curve continued, it would probably level out over time. But what's important to realize is that these curves, these NTCP curves for all these dose constraints are sigmoidal. So if we stay below a threshold, the probability of causing whatever side effect we're looking at is probably fairly low. But after a particular threshold, there's going to be a sharp increase in the probability. So with spinal cord, what are some numbers that we should remember? 50 gray in 2 gray per fractions corresponds to an approximately 0.2% risk of myelopathy. And that's really the number that you should remember. An EQD2 of 50 gray to the spinal cord is probably our max limit for accepted dose to the spinal cord, EQD2 of 50 gray. Why? Because that corresponds to a 0.2% risk of myelopathy, and we do not want to mess with myelopathy. We want to take no chances with myelopathy, and we really try to keep it at an EQD2 of 50 gray generally. We know that if we jump up to 60 gray, the risk of myelopathy goes up to around 6%, and if we go to 69 gray, it jumps up very drastically to 50%. And that's based on these NTCP curves that were derived during these Quantech experiments. So most of the time, if anybody asks you, what would you limit the spinal cord? Our answer is going to be 50 gray at 2 gray per fraction. Of course, you'll see certain exceptions. There are unique circumstances where patients have very harmful tumors that are located very close to the spinal cord. You might see exceptions if you're doing reirradiation. Everything is handled on a case-by-case basis. But generally, if you want to get an answer correct on the board exam, or if somebody's just asking you, 50 gray EQD2 is kind of our accepted dose limit for the spinal cord, knowing that it corresponds to a risk of myelopathy of 0.2%. Sometimes we'll be even more conservative and we'll go down to 45 gray, and we'll try to limit the cord to no more than 45 gray at 2 gray per fraction just to decrease that risk even more. So here's a super in-depth table with some more common dose constraints for different organs at risk, and the dose constraints corresponding to the risk associated of causing a particular side effect. And these come from, like I said, the Quantech studies. If you just Google Quantech studies, there's a nice Wikipedia page that has these tables and they're laid out. And I think it's a good reference to know about. And I refer to the Quantech tables all the time. These just give us, again, dose constraints that have been derived from these Quantech studies where they looked at the risk of causing certain end organ toxicities against a particular threshold dose, and they gave us the risk of getting to a particular toxicity. For the most part, for all these toxicities, we're really looking at late toxicities, right? We know that with radiation, there has to be some degree of acute side effects, and we try to just, of course, limit those as much as possible, but we understand with head and neck cancer, for example, these early responding tissues like the skin, the mucosa that lines our oral cavities, that's going to have a reaction, and we try to get patients through it. But what we're really trying to limit is those late toxicities that are going to affect them for months to years down the road. And so that's what we're looking at. Again, all of these constraints are approximations, and they correspond to an approximate risk of developing a particular toxicity. You'll see that for the spinal cord, we're accepting a very, very low risk of myelopathy because that's such a devastating side effect. For some of the more treatable things like esophagitis, pneumonitis, we accept a higher risk of causing those. And so this is just for your reference. You can Google this at any time on Wikibooks or Wikipedia. There's a nice set of tables from Quantech studies. These are just selected dose constraints from that. I'll just quickly try to go through and highlight some dose constraints that are good to have in your repertoire to be able to kind of just know on the spot. So spinal cord, we already said max dose of 50 gray. Other things that we're constraining to a max dose are things that are in the brain. So your brain itself, we generally accept a max of less than 60 gray. For the brainstem, we accept a max of less than 54 gray. And for the optic nerves and chiasm, it's also very similar, 54 to 55 gray. So those are good numbers to keep in mind. 50 for the spinal cord, 60 for the brain, 54 for the brainstem, as well as the optic nerves and the chiasm. And remember, these are all max doses, and it's easy to remember pretty much all the things in the brain and the spinal cord we think of as max doses. For the stomach, we accept a max dose of less than 45 gray. So 45 gray is a good number to keep in mind just for the stomach. And then for the small bowel, we do a volumetric constraint, And we try to keep our volume that's receiving 45 gray less than around 150 to 195 cc's, depending on what we're treating. So just keep 45 gray in your mind for the stomach as well as the small bowel, and keep in mind that for the stomach it's a max, for the small bowel it's a volumetric constraint. Cochlea, this is going to be a mean dose. So a mean dose of less than 45 gray is accepted for the cochlea. And with this, we're accepting less than 30% chance of sensory neural hearing loss. So again, a higher risk of that end organ damage that we're accepting. But this is kind of balancing the fact that cochlea often receives a lot of radiation when we're treating head and neck cancers, but we really need to be going to those high doses in order to appropriately treat the cancer itself. And so again, it's a risk-benefit situation, but 45 gray mean dose for the cochlea. The other mean dose constraint that people often like to ask about is the parotid glands. And for those, we accept a mean dose of around 26 gray. That applies to your parotid glands and any other salivary or secretory glands. So including the lacrimal glands, which are your tear ducts in your eyes, think about a mean dose of around 26 gray. For the lung, it's a volumetric constraint, V20, somewhere around 30 to 35%. For the esophagus, we like to keep our mean less than 34 generally. For the heart, we like to keep our mean less than 26 generally. For the kidneys, we try to keep our mean less than 15 to 18 gray. And, you can look up the risk of whatever toxicity we're looking at as the endpoint. But these are just some very, very general constraints. It's important to realize that our constraints depend very much on what we're treating, where it's located, and what dose we're treating it to. And all of these really play into our constraints, right? So for example, if you're treating a lymphoma patient and you're only treating them to 20 or 30 gray, there's no way that we're going to accept a heart mean of 26 gray, right? Or even with breast, if you're doing opposed tangents for a whole breast irradiation, the heart receives way less than a mean of 26 gray. So for each site-specific plan, there will be a protocol, or in your institution you might have a template, and these doses always get adjusted depending on what organ we're treating, where it's located, and what our prescription dose is. If we don't need to go higher than, say, 20 gray if you're treating a lymphoma, then you really don't need to be meeting these high means. So these are kind of like the limit, the Quantech dose constraints, and then of course, we'll use common sense, and if we are able to limit these organs further, we definitely will. So hopefully that gives you a good sense of how we think about dose constraints. So far, everything that we have talked about through the Quantech studies has been dose constraints with an EQD2 of 2 gray per fraction. So another series of papers came out after the Quantech studies, and these were called the HYTEC studies. And the HYTEC studies gave us dose constraints for SRS and for SBRT. So this is also something that you can look up, the different HYTEC papers, and they give you dose constraints for 1 to 5 fractions. So for delivering high doses in just 1 to 5 fractions. I have only included the spinal cord here on this slide just because I did not want to overwhelm with tons and tons of numbers. But you can look up the HYTEC constraints as well, and it's a good resource for general dose constraints if we're doing SRS and SBRT. These particular dose constraints for the spinal cord come from Dr. Segal's paper, and they give us dose constraints that correspond to a 1 to 5% risk of myelopathy. Keep in mind with spine SBRT, oftentimes these patients are being re-irradiated, or oftentimes they have different reasons for allowing us to accept a slightly higher risk of myelopathy with SRS and SBRT. But these are also some good numbers to keep in mind. So if we're just treating with 1 fraction, the spinal cord Dmax, according to Dr. Segal's paper, is 12.4 gray. If we're treating with 2 fractions, it's 17 gray, 3 fractions, 20.3 gray, 4 fractions, 23 gray, and 5 fractions, 25.3 gray. So these are all, again, approximations based on studies that have been done, approximate risks of myelopathy for these particular doses. Each actual clinical scenario is going to be case dependent we use our common sense and judgment and the expertise of the attendings that we're working with as well to appropriately constrain the cord. But the biggest thing to realize is that with the spinal cord at an EQD2 of, when we're doing 2 gray per fraction, our dose constraint is somewhere in the neighborhood of 45 to 50 gray. When we drop the number of fractions, our Dmax changes as well, right? So for 3 fractions, it's just around 20 gray. So important to realize that the dose constraints are different for SRS and SBRT. So the major takeaways that we talked about today, our radiation dose and our dose constraint is going to depend on the dose per fraction, the total dose, as well as the alpha-beta ratio of the tissue that we're treating. Treatment time also matters. Remember, it's not accounted for in our BED and our EQD2 equations, but we really do need to consider the treatment time, and we exercise great caution if the patient had prior radiation, especially if they had radiation within the last year. If you're treating very consecutively in time, then it's almost as if it's part of the same course, is how I would think about it. So treatment time does matter a lot. And over time, the body forgets some of the radiation, but not all. But that is a more complicated issue for a later day. The dose constraints are different for series versus parallel organs. Remember, series organs like the spinal cord, we worry more about a point dose. And parallel organs like the lung, we worry more about a volumetric dose. So keep in mind what is the nature of the organ that you're treating when you're thinking about dose constraints. For disease site-specific protocols, you'll see different dose constraints. And as always, we use our common sense. So if we are not treating to a total radiation dose that's more than 20 or 30 gray, for example, there's no need to accept a heart mean of 26 gray. We drop that heart mean a lot. For breast plans, we try to keep our heart mean somewhere in the neighborhood of just 2 to 4 gray even, or even less than that if we're able to. And same thing for lymphoma. If we're treating like a mediastinal lymphoma, we try to keep that heart dose very, very low because we expect these patients to survive for a long time and we want to limit their risk of cardiac side effects. Quantech and HYTEC are great references for conventional and SRS-SBRT constraints respectively, and a good tool to have in clinic when you're comparing different dose fractionation schemes is to always go to that EQD2 or BED calc and kind of convert them to an EQD2 so that you can compare apples to apples. And that is all I have for now. Hopefully this was a helpful overview of considering dose constraints. And hopefully you got something out of it. Thank you so much for your time.